Welcome, everyone. We're going to go ahead and get started. My name is Christina Ward. I'm a dietitian at St. Louis Children's Hospital. And Jennifer is my co-moderator, and we're going to be moderating. In the beginning, there was nutrition, early childhood feeding. Our learning objectives for this Lunch and Learn session, we're going to review birth to 24-month growth chart recommendations, discuss nutritional consideration for the hospitalized infant from both nutrition and behavioral perspectives, and describe best practices for early parent nutrition education from a parent and a professional point of view. We have a great session with a lot of great speakers today. Karen, do you want to say? Yeah.
So we have a lot of great information, so we're going to introduce all of our speakers right now, and then we'll ask them to come up when it's their turn to speak. So starting with Karen McGinnis. Karen is a dietitian for the Department of Pediatric Pulmonology at Riley Hospital for Children in Indianapolis, Indiana. She's provided nutritional care to patients and families with cystic fibrosis for over 35 years. She's a board-certified specialist in pediatric nutrition and is a nutrition mentor for the CF Foundation, as well as the Pulmonary and GI Fellows at Riley Hospital for Children. So she's very well accomplished, and we're so glad to have her come speak with us today.
Then we're going to have Susan Gemma speak with us about nutrition in the NICU. Susan is a registered dietitian. She works at the Nationwide Children's Hospital in Columbus, Ohio. She received her master's degree in nutrition from The Ohio State University. She has worked at their Cystic Fibrosis Center for over 30 years, covering both pediatrics and adults. She has an interest in early childhood nutrition in the NICU, specifically patients with meconium ileus. So we are very grateful Susan has agreed to speak with us today.
After Susan, we have my colleague, Dr. Melissa Anderson, who will be speaking to us about cue-based feeding. Melissa is an assistant professor of pediatrics, pediatric psychologist, and director of the NG follow-up clinic within the interdisciplinary pediatric feeding program at the University of Michigan CS Children's Hospital. She served as the PI of a large-scale quality improvement grant focused on improving the hospital-wide approach to promoting oral feeding skill acquisition in hospitalized infants and preventing feeding disorders in this high-risk population.
Then we have Katie Kroon. Katie is a nurse, but she is also a mom to two children, one being Anders, who is 4 with cystic fibrosis. So she is going to share her stories and her experience and their whole family experience with their early childhood feeding.
And Christina and I will wrap it up with best practices for nutrition education in the first year. I'm a pediatric psychologist at the University of Michigan, and one of my roles in the clinic is to help with behavioral support around feeding challenges. So we'll go ahead and get started with Karen, if you want to come up.
So good afternoon. Again, I'm Karen McGinnis, and I'll be presenting today on the CDC and WHO growth charts in children with CF who are under 2 years of age. I would like to thank the CF Foundation and the moderators of the session for inviting me to speak today. I have nothing to disclose. So my objectives for this presentation are to highlight some of the differences between the WHO and CDC growth charts, to recognize that many of the established infant nutrition guidelines in CF are based on data using the CDC growth charts, and finally, to suggest consideration of CF centers to use the CDC growth charts in children with CF who are under 2 years of age. This presentation does not imply that the WHO growth charts are invalid or that their data is being questioned. This is not the first time the differences between the two growth charts have been presented at NACFC. Dr. Lai presented her data on this at the 2015 NACFC conference, and there was also a handout from the CF Foundation that went out to all CF centers around the same time. Additionally, there were two papers published in 2015 that discussed the WHO and CDC growth charts in infants with CF. One from Dr. Evans Machogu, published in JPGN, and the other by Dr. Zhang in the Journal of Pediatrics. Very sadly, Dr. Zhang passed away this past year, and our sincere condolences are with her coworkers attending this conference. There are two growth charts available to use for infants under 2 years of age, the CDC, which spans from birth to 36 months, and the WHO, which spans from birth to 24 months. This slide shows the boys' growth charts of each. And as you probably know, there is just one chart available for children 2 to 20 years of age, the CDC growth chart. For the first 6 months of life, weight for age on the WHO and CDC growth charts plot very similarly. After 6 months of age, differences begin to develop. If you're interested, you can go to the cdc.gov growth chart website and find the actual weight data that corresponds to what percentile the child will plot at on the two different growth charts. For example, circled in red on this slide, it shows that a newborn male who weighs 3.53 kilograms plots at the 50th percentile on the CDC growth chart. This slide and the next are to help you visualize some of the points I'm trying to make. The black dots were hand plotted to the best of my ability. On this slide, you see what CDC raw data, weight for age, at the 50th percentile would look like if plotted on a WHO growth chart over time. Again, for the first 6 months of life, the percentiles closely follow each other. However, by 12 months of life, the CDC 50th percentile weight plots near the 75th percentile. By 24 months of age, the CDC weight drops slightly and plots between the 50th and 75th percentile on the WHO grids. Conversely, on this slide, this is what it looks like to plot WHO raw data weight for age at the 50th percentile on a CDC growth chart. Again, for the first 6 months of life, percentiles closely approximate each other. By 12 months of age, WHO weight for age data decreases down to the 25th percentile. By 24 months of age, WHO weights increase back up slightly on the CDC grid between the 25th and 50th percentile. So a brief history on growth charts. The CDC growth charts were released first in 1977. The data for these came from the Fels longitudinal growth study. The data lacked diversity as most of the infants were formula fed. There was also a discrepancy in length and height measurements when transitioned to the growth charts used for older children. In the year 2000, updated CDC growth charts were released. The 2000 data came from the NHANES 3 study and corrected for the concerns cited with the Fels data. In 2006, the WHO growth charts were released. This data came from the Multi-Center Growth Reference Center. In terms of the database for the two growth charts, the CDC was cross-sectional, meaning that every data point was from a different child, whereas the WHO growth chart data was longitudinal, meaning that the same group of children was followed over time. The CDC data came from the United States only, whereas the WHO data was multinational. Also, the WHO data included only children who were considered healthy. Children with any type of illness or disease were excluded, and this was not the case for the CDC data. As mentioned, the WHO data was multinational. This slide shows the 6 different areas around the world from where the data came. Another major difference was breastfeeding versus formula feeding. 100% of the infants from the WHO database were initially breastfed, and by 3 months of age, 75% were still breastfeeding. So, in summary, the WHO data is defined as a growth standard and describes the growth of children under optimal conditions. The CDC data is a growth reference and describes how children grew in a particular place and time. The hypothesis when creating the WHO growth charts was that all children have the potential to grow similarly if in a healthy environment and receiving adequate nutrition. In 2010, the AAP recommended using the WHO growth charts in place of the CDC for all children under 2. Over time, electronic medical records changed over to populating growth data on the WHO instead of the CDC growth charts. Here you see the weight in kilograms needed to plot at the 50th percentile at 24 months of age on both the WHO and CDC growth charts. You'll notice a difference for boys and girls, and also that the CDC growth charts require a higher weight. As shown in the last 2 rows, you can see 24-month-old CDC weights on the infant CDC chart exactly correspond to a 2-year-old weights on the 2 to 20-year-old CDC growth chart. So why are we reviewing this topic again since it was already reviewed in 2015? 4 reasons. First, maybe you're new to CF since 2015 and you haven't heard this before. Second, maybe you're not new to CF and you have heard this before, but you forgot. Third, it's important to have a clear understanding of the research and data behind the growth chart you choose to use. And 4, because Terry asked me to. So, if you plot a baby who has CF on a WHO growth chart for their first 2 years of life, here's what happens when you transition to the CDC growth chart at age 2. The percentile they were plotting at goes down. This decrease in weight for age can be disconcerting to both parents and care providers alike. The weight percentile looks good, and then it doesn't. By starting with the CDC growth charts at birth, when it comes time to switch to the 2 to 20-year-old growth charts, the percentiles stay exactly the same. When using CDC growth charts for your infants in CF clinic, it's important to mention to families that they may notice a difference between what their CF clinic says the weight percentiles are and what the PCP says the weight percentiles are, because the PCP is probably using the WHO growth charts. It may help to say something like, you may hear a higher weight percentile at your pediatrician's office and a lower one here in CF clinic. Your baby's going to have to work a little bit harder on our growth charts to have a higher weight percentile. And I find that most parents seem to enjoy this challenge. This handout was recently developed by members of the CF Foundation's 2023 working group on use of WHO versus CDC growth charts in infancy. It talks about the differences between the 2 growth charts and is intended for parents and caregivers of infants with CF. Input was also sought from CF Family Advisory Board members in its content and design, and this handout will be made available on the CFF Nutrition listserv. And this slide is just to show that no matter what type of computer system your hospital uses, there's almost always a way to go through a few quick steps and change which growth chart you can plot infant data on. The PD Tools app and website is another convenient way to know z-scores and percentiles for anthropometric data on both the WHO and CDC growth charts. So I'm hopeful that you learned the following key points today. Weight for age percentiles will decrease if babies are started on the WHO growth charts when changed over to the CDC growth charts at age 2, and this has the potential for confusion as well as parental distress. Secondly, many of the landmark nutrition and pulmonary studies done in CF use data from the infant CDC growth charts. And lastly, perhaps future research should be done in this area, especially as related to pulmonary function outcome. I would like to acknowledge all of the individuals listed on this slide for their dedicated work on this topic. Thank you very much.
Thank you very much. We're going to have questions at the end. We'll have a Q&A period. If you want to go ahead and put questions as you think of them into the app, or you can come up at the end and ask any questions that you have. So next up, we have Susan Gemma talking to us about nutrition in early life inpatient.
Good afternoon. I would like to thank Jennifer and Christina for inviting me to speak on this topic. It gives me an opportunity to review everything that myself and my colleagues at Nationwide Children's Hospital have learned over the last decade about these babies born with meconium ileus. It's not moving ahead. Okay, we'll do that. No, the clicker's not working, and neither is this.
Yeah, it just was. It just was. That, there we go. Now, I guess. Okay, sorry about that. So forward?
Forward,
Backwards.
yes, okay. Of course, I had this timed perfectly, so I've already lost a minute. I have no relationships to disclose related to this presentation. My objectives today will be to briefly review the anatomy and the key functions of the GI tract, and to identify the nutritional implications and complications of managing a baby born with meconium ileus. It's important to know the GI anatomy in order to better understand the significance of the patient's course. As we know, small does not refer to the length, but rather to the diameter of the lumen in the small intestine. The small intestine is the most important organ in digestion and absorption of nutrients. And there's approximately 200 to 250 centimeters of small bowel in the full-term newborn. The first section is the duodenum. It's the common bile duct and the pancreatic duct empty into the duodenum to neutralize the acid contents of the stomach. Most digestion of carbohydrate, protein, and fat starts in the duodenum. The second section is the jejunum. The ligament of Treitz is an anatomical landmark in the transition from the duodenum to the jejunum, and is often referenced in those the initial surgical report for the baby's status post-meconium ileus. The jejunum is the site of greatest nutrient absorption. The third section is the ileum. It's more narrow than the jejunum, the only receptor site for vitamin B12 and bile salts, and is the last place of absorption for amino acids and the fat-soluble vitamins. It has less overall absorptive capacity. The ileocecal valve connects the small intestine to the large intestine. It slows the emptying from the small to the large intestine, and the removal of the ileocecal valve increases the risk of small intestinal bowel overgrowth due to more rapid bowel emptying. As you can see from those slides, that any injury to the infant's small intestine greatly increases the risk of or compromises the nutrient absorption and increases the risk of the newborn, places the newborn at nutrition risk. Meconium ileus occurs in 10 to 20% of infants born with cystic fibrosis. The meconium is abnormally viscous in consistency, and the sticky mucus in the CF gut, often referred to as insipated, that's a new term, but it just means it's a very sticky meconium in the baby's intestinal tract. And this is what contributes to the bowel obstruction. In addition, loss of bicarbonate-rich fluid in patients with EPI alters the intraluminal milieu, and this also is a contributing factor to the intestinal contents, the dehydration of the intestinal contents. Most of the babies born with cystic fibrosis and meconium ileus have more severe genotypes that are found in class 3 through class 1 through class 3. And that includes the delta F508 and the mutations ending in X. Perforation of the bowel may occur in utero or shortly after birth. Failure to pass the meconium within the first 24 to 48 hours of life is always a red flag. And infants present with abdominal distension and or bilious emesis secondary to the intraluminal obstruction. There are two types of meconium ileus. Simple may be dislodged by gastrographin enemas. However, the rate of success varies between 30 to 50%. If unsuccessful, infants will require exploratory laparotomy, which may result in a bowel resection or an ostomy. The post-operative course for babies with simple meconium ileus can often end up being very complicated. Then there's the complex meconium ileus, and that involves an obstruction of the bowel, which results in a perforation, a volvulus, bowel atresia, or meconium peritonitis. It's always considered a surgical emergency and may require intestinal resection with an ostomy and or a mucus fistula. There are many factors that determine the nutrition management and progress of these babies born with meconium ileus. The nutritional management depends on the location of the bowel obstruction, creation of the ostomy, and the length of bowel resection. If the obstruction is resolved with enemas and no surgery is needed, PO feeds can be initiated with breast milk or cow's milk-based formula. With a bowel resection, which includes an ostomy and or mucus fistula, full TPN is given until bowel sounds are present. And post-surgery, a baby that has had an ostomy, the feeds are cautiously initiated with either breast milk, semi-elemental, or elemental formula. TPN in combination with PO or enteral feeds provide adequate calories until the bowel is reconnected. There's the gradual progression of PO or enteral feeds is based on the ostomy output, and what you would want to see is less than 25 mils per kilo per day for ostomy output. If that is the case, then feeds are usually advanced in the NICU by 20 mils per kilo per day. However, poor tolerance to gradual increase in volume of oral intake should prompt consideration for continuous NG or NJ feeds, just to slow that rate of formula or breast milk through the GI tract. If a baby is on enteral feeds, pausing the feeds and allowing 1 to 2 hours worth by mouth will help to maintain oral feeding skills. And this is just a diagram of an ostomy with a mucus fistula. The mucus fistula may be beneficial for the refeeding of the mucus fistula, may be beneficial for the proximal bowel and colon. There's always a lot of controversy over when to initiate pancreatic enzymes. And from our experience, surgery may recommend starting enzymes as soon as the infant is receiving just a small amount of human milk or formula. However, initial trophic feeds contain negligible fat and do not require enzymes. And sometimes the CF dietitians have to remind the NICU team that we're not ready to start those enzymes just yet. We have learned that increased ostomy output is not always due to absence of enzymes. And there's so many other factors that can affect the transit time of for these babies. We recommend starting enzymes between 50 to 60 mils per feed of either formula or human milk, and that provides about 2 grams of fat per feeding. If possible, the CF dietitian demonstrates in the presence of the parent and the nurse how enzyme beads should be given. And we also always document in the patient chart, as you can see here. It's just important to emphasize that to open up the capsule and place the beads on a scant teaspoon of applesauce and give these enzyme beads before each feeding. If an infant is not taking PO, there are alternative options available. Some centers crush the non-enteric coated enzyme tablets based on the CHOP protocol and add that to enteral feeds. At our center, we have crushed low-strength enteric coated enzyme beads and allowed to dissolve in the formula or expressed breast milk. In addition to demonstrating the CF dietitian at our center, we do try to visit the patient when the parents are there, especially around feeding time, just to observe the tolerance of the enzyme beads as well as how well they're feeding. We always re-emphasize, just give a small amount of applesauce on the teaspoon, since the osmolality of the applesauce can contribute to an increased ostomy output. And it's also important to confirm the timing of the enzyme beads. Some medications are dosed every 3 to 4 hours, and you want to make sure that those beads are coordinated with each feeding. The CF dietitian closely monitors the enzyme dose, hopefully as the baby's gaining weight and increasing the volume of feeds, that the enzyme dose may need to be also increased. The infant's status post-meconium ileus, as you can imagine, needs increased calories, secondary to the fat malabsorption, need for catch-up growth, and healing from surgery. 120 to 150 calories per kilo per day is recommended, and it may be necessary to concentrate formula or fortify breast milk to 24 to 27 calories per ounce to meet the increased calorie needs. We start the CF-specific vitamin drops when the TPN has been discontinued. And the standard dose for these vitamins are 0.5 mils per day. However, due to the hyperosmolar solution in these vitamins, we recommend dividing that dose to 0.25 mils twice a day. We also initiate the salt supplement when the TPN has been discontinued. And pharmacy prepares the sodium chloride solution equivalent to 1/8 teaspoon of salt. And those usually come up in little vials, and so the nurse can just add those to the feeds throughout the day. When feeds are initiated after surgery, we prefer starting breast milk if it's available. The lactation consultant always meets with our mothers within 1 to 2 days of the baby's admission to help with the pumping. However, as you can imagine, having a baby in the NICU is very stressful, and over time, many of our mothers' milk supply decline, so they're forced to switch over to formula. If formula is desired, standard versus an elemental formula is dependent on the bowel resected and the location of the ostomy. There's a lot of monitoring that goes on with these babies. We're fortunate that from the CF perspective, the NICU team, they always monitor the TPN labs. If the baby is demonstrating poor weight gain, we would recommend urine sodium be done just to check on that. There's daily monitoring of weight, stool, and ostomy output. Length and head circumference are measured weekly. Both the CF dietitian and the NICU dietitian assess the calorie and protein intakes of these babies based on the TPN and the enteral or oral intake. And we recommend checking the stool elastase once the baby has been reanastomosed, because it's more accurate coming from the rectum and it's not as reliable from the ostomy contents. There's many challenges for babies, status post-meconium ileus, and I feel like one of the greatest challenges is promoting positive weight gain. And the goal of 30 grams per day may not always be realistic until the baby has been reanastomosed. As I mentioned, the CF dietitian collaborates closely with the NICU dietitian to problem solve, especially if the baby is not tolerating oral intake, or there may need to be a trial of a different formula, or increasing the caloric density of expressed breast milk. Another great challenge is just the balance of gradually decreasing the TPN while increasing PO intake to maintain that adequate calorie intake. And of course, supporting parents and caregivers during this long hospitalization is paramount. The keys to success, the CF team and the CF dietitian are consulted on these infants as soon as we learn of a baby in our NICU, though we follow their progress closely and are available to make recommendations as warranted. There's always needs to be close communication between the NICU and the CF team, and it also include the parents. And it's a interdisciplinary approach for the success of these babies, including OT, social work to navigate the insurance issues, and the intestinal support team if the baby is deemed short gut. And of course, the lactation consultant is a tremendous support to the mother. And this is one of my favorite patients. He will be 3 on Saturday. He was in the hospital for 2 months, status post a simple meconium ileus, but he ended up having ostomy and a mucus fistula. And his mother expressed breast milk throughout his hospitalization, and she was able to transition nicely to direct breastfeeding once they got home. Thank you.
All right, thank you. Please keep the questions coming in the app as you think of them. Next up, we have Melissa Anderson. So we're going to switch gears a little bit to a behavioral approach to promoting positive infant feeding interactions.
Thank you.
We've got to unplug this and replug it after every morning.
Oh, okay.
Well,
that's good to know.
yeah, that's what I'm just.
And I hit this to.
Can you test that
progress
for
it?
me and see if it works? Maybe I have to click on it first, and then we'll try it. Now try with the clicker.
Got it. Excellent. All right. Thanks, guys. I have nothing to disclose. So as you may be well aware, it's pretty well established that infants who are born either prematurely or with chronic medical conditions, there's a really high rate of feeding problems in this population. Specific to CF, we have evidence that there's, compared to otherwise healthy kids, there are a lot more, actually significantly greater reported feeding problems in this population in infants and young children. And we also know that if left without intervention, it doesn't go away. Oftentimes it actually gets worse and they persist. And so, especially in our program, we take an aggressively preventative approach to this, and really just so that we can promote appropriate oral feeding acquisition and prevent these problems from the start. And so to do this, we have to really understand what goes into infant feeding development and what the infant's feeding experience is like. Our program uses a kind of like a biopsychosocial model. All of these different factors go into oral feeding acquisition. They also have a dynamic interplay and affect each other. And so we keep our eyes on all of these factors and how they go into oral feeding acquisition and readiness. From a medical perspective, really anything that impacts a baby's breathing, their endurance, their comfort, physiological experience when they are eating or when they're being fed, their tolerance. So specific to our CF population, we're really we're looking at everything, but we're really keeping a close eye on their respiratory and GI systems, because those two systems are very often impacted with CF. From a developmental perspective, we really want to make sure that we're understanding what should we expect from a developmental level, from from a biological perspective, what would be appropriate or what should be expected at their gestational age, at their developmental age. Endurance, fatigue, coordination all play into that. Intolerance, volume, that kind of thing. Psychosocially, we're looking a lot at how the dynamic between the parent and the infant, the parent, the whole kind of the family system, and the parent's well-being. What are their supports? What are their cultural beliefs around feeding? What is their understanding, their health and developmental literacy, cognitive functioning? All of this plays into oral feeding progression as well. And then we're looking at the obvious stuff. When are they being fed? What are we basing starting a feed on? Is it based on just the time? Like they need to have this much in the day. Let's divide that by 8 feeds. This is what they need every 3 hours. Or are we basing it? Are we using the infant's cues and what they're telling us to base starting and stopping an oral feed? Who's feeding? How consistently are they feeding? What strategies are they using? What are we feeding them? How much are we feeding them? All of that plays into it. And early on, a really common phrase that we use is neurons that fire together, wire together. This is often used in the NICU or understanding just neurodevelopment in general in our newborns. And this plays very much into infant feeding and oral feeding acquisition and progression. And really what it means is, what are they experiencing when the bottle's in their mouth, when they're breastfeeding, when they're eating, what are the other experiences that they're having? Because those connections are being made early on. And so a good example of this, because it's not just specific to infants, a good example of this is if anyone's ever had food poisoning or had the flu or been really sick. Where I'm from in Michigan, whenever we're sick, moms always gave us ginger ale every time we were sick. So they're always telling us to sip on ginger ale. And I've talked to more than one person who has said that whenever they, as adults, see or smell or, see ginger ale, they start to feel icky, and they're like, oh, like they just kind of have that feeling take over. They have this aversion to it because their wiring early on was ginger ale, feeling sick. And so the reason this happens is this phenomenon called classical conditioning. If you've ever heard of Pavlov's dogs, basically it's the same concept. Whenever we're pairing an otherwise neutral stimulus, like a bottle, you don't really have feelings about a bottle either way. A feeding position, a room, a person, whenever that is paired with physiological discomfort or stress, so reflux, vomiting, constipation, cramping, gas, fatigue, choking, difficulty coordinating, what happens is that otherwise neutral stimulus turns into this conditioned stimulus this aversive stimulus. So whenever the baby sees that bottle or gets put in that feeding position, they experience stress. They are more likely to have adverse feeding events. They're more likely to refuse. And this can just kind of spiral. This is the reason why they don't tend to go away over time. It tends to get worse. And when you're talking about really new, like neonates, newborns under the age of 3 months, they may be experiencing these things. They may be showing stress cues, but they still keep eating. And the reason is because they have sucking, swallowing is a reflex. It's an involuntary behavior that early on, for obvious reasons, for survival, they have to eat to survive. And so around that 3-month mark, if you're starting to notice that you have a baby who's starting to refuse feeds a lot, refusing the bottle, turning away a lot, it's because that has transitioned into a volunteer behavior. They can choose whether or not to engage. So that's why it's really, really important that we're keeping in mind this foundational period of time and really taking their experience into consideration. And that's because the first 10 months of life is a sensitive period of feeding development. So the skills of, eating, sucking, and swallowing, but then also then progressing to being able to progress with solids, increased advanced textures, table textured foods, etc. Being able to chew and manipulate food and swallow it, all is learned so much easier in that first 10 months of life. If they don't learn that, then it becomes so much harder and takes a lot more intensive and longer term intervention. And so that's why really keeping all of these things in mind is really important. So let's say during this period of the first, 3 months of life, they're having consistent GI discomfort when they're taking bottles. They're uncomfortable, but they keep going. What's going to happen is as soon as they have the ability to avoid eating and experiencing that stress, that discomfort, they're going to stop. And then what happens is then that kind of derails the progression of the subsequent oral feeding skills that they might be able to develop. So delayed exposure to textures, very limited oral acceptance, easy gag, hypersensitivity in the mouth, that sort of thing. And so it's important to think about this in the hospital, but these concepts also apply after discharge and often times really kind of come out after discharge for a lot of these reasons. And so that's why it's really important to focus on the experience, that the oral feeding experience in general, because especially in the CF population, there's a much higher risk of physiological problems that are occurring that would impact their experience with oral feeds. And there's so much pressure, especially in this population, to get infants, and young children to eat more, eat what they need. And oftentimes on the outpatient side, all of the different care can be really disjointed. You might have, the dietitians in the clinic and the physicians in the clinic, but then a feeding therapist separate and other, important feeding providers. And so care kind of becomes disjointed and confusing. So that's why it's really important to really focus on, the foundation of oral feeding progression is it safe? And are they physiologically comfortable? Is it stress-free? And then you can kind of build and progress from an oral feeding standpoint. So how to do that is following their cues. It seems really simple and straightforward. It is not in practice, especially in the inpatient side. It becomes a lot more challenging in the hospital. But in general, sort of the recipe for building and protecting a really solid oral feeding foundation and progressing is to start and stop the feeds based on their cues and their physiologic stability and readiness. Awake, alert, cueing, hungry. And really focusing not on the volume, not on the amount that leaves the bottle or the amount that the infant takes. It's really focusing on the quality of the experience, whether it's 5 mLs, whether it's 50, whether it's 150. If that was safe, comfortable, and positive, it's a success. And now this is assuming they have a tube, really being able to use the tube as a tool to keep stress, discomfort separate from the oral feeding experience so that they can progress as they're ready. Making sure that's consistently comfortable, safe, and positive, like I said, and really focusing on, we're looking a lot at poop and reflux, the different, both ends, and looking at, what's coming up and out, and making sure that really stays a priority to make sure it's well managed. And really adjusting what and how much we're giving based on what they're able to take, and not needing to you don't need to sacrifice nutrition and growth for positive oral feeding experiences. So in our program, we use the tube as a tool to make sure feeding stays safe and comfortable and positive. And this approach has a lot of great and compelling research supporting the efficacy, and shows that there is a lot of, it decreases adverse feeding events and development of feeding problems, and it doesn't necessarily negatively impact weight and nutritional intake. All right, so I was hoping I would have a time thing, but I only have a few more. Oh, there we go. Perfect. So what to do when the feeding course isn't going as planned? If they're having slow oral feeding progression, especially on the inpatient side, then what to look for is really to kind of pull back in that that kind of biopsychosocial model. Look at all of the systems here from a physiologic standpoint, from a developmental standpoint. Are they even old enough to expect them to take a full oral feed consistently? Especially if we have a baby that's born prematurely, or if they've had a lot of, if they had surgery early on, if they've have any kind of other system compromise, they're going to most likely need a little bit more time. And so we want to make sure that we keep all of those things in mind. And we want to make sure that we're bringing in all of the different specialties that can really inform all of the things that are impacting. So make sure that we're looping in our speech language pathologists and our occupational therapists, and so that they can chime in on what's going to make feeding a safer and more comfortable experience. If they're not having, if we're concerned about weight gain, we in our program work very, very closely with our dietitians that are always part of our visits. And for a very important reason, we really my assessment and my recommendations hinge on their assessment and their recommendations, and vice versa. It's a really collaborative experience. So oftentimes what we're going to do is, can we obviously increase concentration, increase feeding volume if they can tolerate it? Can we play with the timing or the schedule, and look to see how much they're losing from spitting up and vomiting, and are there things we can play with there? What we don't want to do is just arbitrarily limit how much we're giving them orally, because it's not going to, if they have a tube, I should say. If they don't, it's different conversation. But we don't want to make sure that we're only focusing on PO intake without looking at all of these other factors. And we don't especially want to push them to take more if they're telling you that they need to stop, because that is a really great way to develop feeding or cause feeding problems. If there's a lot of vomiting, oftentimes we're asking, well, how are they pooping? Is there constipation? Is there something going on that may be impacting the vomiting? We're looking at reflux and providing reflux support, and treating that and really focusing on that. We don't want to dismiss that, and we don't want to ignore stress and discomfort. So we really want to look at their cues from a discomfort standpoint and address that. And I think this is almost my last slide. Oftentimes when we're transitioning formulas or we're increasing concentration, there can be intolerance, there can be negative impact on stooling. So what we want to do is just make sure we're providing a lot of that physiologic support. Maybe we slow down, take a really gradual approach to transitioning or increasing concentration, and really addressing kind of the symptoms that are coming along with that transition. And what we also want to do is just make sure we're trying to make really systematic changes, one change at a time if we can, and just kind of sticking with that, letting them adjust. But we never really want to deviate from following their cues, feeding them when they're showing that they are engaged and want to engage and can, and then stopping if they're saying no, when they're showing that those disengagement cues or discomfort. And then I think I may have actually, some of the questions that we often will ask is, if they're having, there's a range in what's normal for stooling, but what we want to look at is, what is the experience? Are they straining a lot? Are they crying? Is there seem to be discomfort, but their poops still look okay, and they're pooping a decent amount. Can we make changes there to make their experience better? Can we address gas? Are we looking at all of the different symptoms of reflux? Are they happening during oral feeds? And what can we do to address those? Things so that we can make sure that the oral feeding experience stays, nice and comfortable and positive, and they can progress when they're ready. Okay. I got a lot of references for you guys, so. Okay.
Thank you, Melissa. Keep those questions coming, please. Next up, we have Katie Kroon, who's going to give us the parent perspective on some of this.
Okay, if you hear paper flipping, I have to have it physically in front of me. So, I'm Katie. I have nothing to disclose. Oh. Excellent. Okay, so first of all, who am I? I'm a mom of two. My oldest is Anders. He's 4 years old, and he is my child with CF. I have degrees both in biology and in nursing. My biology did do a lot of genetics foundation, so that was a bonus. Most of my experience has been with pediatrics for nursing as well. So, who is Anders? He is my spirited 4-year-old with CF, who is too smart for his own good. His diagnosis did start with the newborn screen. So, we were originally in Indiana when this happened. It was when the Fort Wayne clinic was still around, so that's where we were actually diagnosed at. His newborn screen flagged as positive for the IRT, and then when they did the genetics, only one gene showed up. So we were told it was more than likely going to just be a false positive. Per Indiana protocol, they had us do sweat tests, which one of them was like 98, the other one was 101. So there was no question as to if he had it or not there. From there, his blood got sent off to Johns Hopkins, and then we got back that he has 508 and L1077P. Also, just for reference too, he was pancreatic sufficient up until about 8 months old. So if you take nothing else away from my talk here, just keep in mind listening and creativity are going to be two very important things. So here's a picture of what we survived off of for the first at least 2 years. Especially that Ensure Clear really kept us going for a while there. So just kind of going into also that creativity and listening, because I scrolled past this part. I feel like listening a lot is going to be within that first year. Your families are starting to get used to the whole diagnosis. They're getting used to a new baby also. There's a lot of confusion. There's a lot of postpartum feelings happening. There's a lot of explaining to extended family, which can also be very difficult depending on what they're working with. So just being there, listening, encouraging is very important for that first year. One thing that I know goes around the CF family community a lot is if you haven't read the Welcome to Holland poem by Emily Kingsley, definitely look it up. It's great. And then the creativity, I feel like you see a lot with those toddler years, 2-year-olds especially. We'll get into that with how we had to get creative with him. So just for comparison, Anders on the left was, I believe, 3 or 4 months old in this picture. And then his sister in the other picture is on the same blanket at about the same age. So just kind of a size difference. I know it's a little skewed on the screen, but there was substantial size and weight differences between the two. Plus, I can put pictures in here, so why not? So I did put up some of his just first year information. Those percentiles are in the WHO because it came from our pediatrician. So just keep that in mind because now I know that that's a big thing. So within the first year, we started off breastfeeding. I was very dead set on that's what I was going to do. I had very strong feelings about it. I was actually an overproducer, so that was not a supply issue for us. But he just was not able to gain weight on it. So slowly we started adding in 1 fortified bottle a day of breast milk. We did it with his night bottle because that seemed to be the one that he would do the best with. And he was kind of gaining. Eventually we just kept stacking on more and more fortified bottles just because he wasn't gaining very well. Eventually, we did switch over to just full formula, partially because there was a lot of mental health stuff going on as well with me postpartum. And again, I had very strong feelings about breastfeeding. So the fact that he was not gaining with what I was providing was a very big issue for me. Also, I was working in adult med surg at the time, so pumping was not very feasible at work. Again, just the guilt is something to definitely keep in mind with your families. Feeding is just a very high emotion topic. There's a lot of frustrations with it. Your families are dealing with this day in and day out. It feels like a fight. There's people outside of the immediate family who might be questioning what they're doing constantly or saying they're doing it wrong. So the amount of guilt that your families could be feeling can also play a big part in how the whole eating thing is going for the child. Also within that first year, Anders just really didn't have much interest in eating in general. This did continue on, but has gotten a little bit better as he got older. And then we introduced food a little bit early. They had us start about 4 or 5 months old, just with like the baby oatmeals, applesauce. He survived off those little applesauce pouches with like oil put into it for a little bit too, because that's all he wanted. And then enzymes we eventually started right around the 8-month mark. So just another thing that I see within the CF family community to keep in mind too is there's a lot of stress and a lot of confusion regarding enzymes, especially with like closer to the newborn stage when you're doing cluster feeding and how to kind of manage that. And more than likely, again, you're dealing postpartum and a lot of other things going on. The family may not reach out to you and ask about it. So make sure you're having those conversations and make sure that you are, if possible, giving like a handout. I had genetics backing, I had nursing background, I had all of the background that should have made diagnosis teaching easy. But let me tell you, as they are telling me all this information, right over my head. Almost nothing was retained, but I could go back to those papers, look at those. I can hand them to, like my mom does babysitting. I could give her the papers and be like, here is what you need to know. And it was one more thing off of us so that we could focus on actually taking care of him. And then again, mom may not be thinking of herself very much during this because there's a lot going on. I have seen a lot of people who are very sensitive, like skin integrity wise, if they are breastfeeding when the baby's getting enzymes. So just make sure you're supporting them with that as well. Just the general fighting to eat can be a lot of trial and error. He did have a lot of spit up, a lot of throw up, that kind of thing when he was little. We had to go through, I don't know how many formulas to figure out what actually worked for him. So again, supporting family as they're trying to figure out what to do with all of this. Around the end of his first year, he just got like a GI virus kind of thing. It started off with just a couple days. He was throwing up quite a bit. And then all of a sudden just refused to eat, refused to drink for probably about a week. Ended up being hospitalized, got some IV fluids, and then after that, it got better a little bit, and then he just started having these random episodes for months where he would just throw up pretty much everything that he had eaten. So this was also adding stress to everybody. nothing was necessarily figured out as to why, which can also be extremely frustrating. So encouragement for your families, be like, yes, I know you're trying everything you can. I can see that we've gone through this, and this, and it's just not working. That reassurance is also key for your family to feel like they can actually handle this. And if they don't feel like they can handle the CF side, they also are probably not feeling like they can handle just the general parenting a child side. So as far as the second year, this is when you just want to help find a balance. So making sure your family knows what is your max dose of enzymes. Christina gets this question a lot from me. Where are we at? What can I do with this? Because this child just likes to graze. He wants a little bit here, a little bit here. How can we manage this? But also, just don't fight the 2-year-old. It's not going to work. The stubbornness contest is not a fun time for anybody. So this is when we're going to pull out our creativity card here. So what can we actually do with this? So the first thing we did was we added the butter, we added heavy cream. We attempted to give him dips, which he wanted none of. The kid loves his fruits and vegetables, which was great, but it was very frustrating at this time, being like, just take the ranch. So give choices, try to get them to help cook. All of these things were things that we tried, but that didn't work. So moving on to supplements, Christina brought us all kinds of presents. We had, trying to think what we did do. We did the Ensure, we did Cape Farms, we did Pediasure, we did DuoCal, we did all of the things to just Carnation, everything to just try. So I would be sitting in the kitchen with a blender and I'd be like, here's some Pediasure, we're gonna put some like Benical in here, what else can I get in this child? So yeah, just try and figure out what actually works. What if that doesn't work? Or maybe what if family can't afford the supplements? These are all things to keep in mind, and more than likely a lot of families are not going to bring up to you if they have a cost concern, at least until it's to the point where it's being really pushed, because no one wants to admit, like, I can't get this thing for my child that they need. So again, we're going back to that time for creativity with those strange little toddler creatures. So one of his favorite things I noticed, and this was on one of those nights where I was just so frustrated, I'm like, I need to get something in you. I don't know what to do. And we had mint chocolate chip ice cream. And it's not going where you think it is, because you're going to think I'm just giving him the ice cream. Yeah. That's not it. So he had an obsession with mint chocolate chip ice cream. So one day in my desperation, I'm like, you know what? Pediasure's chocolate. I have this like mint like oil thing to put into baking. So we started making mint chocolate chip like Pediasure shakes. So like these are just kind of things you don't think about, and like at first you're mixing this, you're like, ooh, this is really weird. But if they eat it, by all means, like he was getting what he needed. So even if it's unconventional, just try it, see what happens. Worse is it also doesn't work and you move on to the next thing. And again, just reiterating, this can be a topic that has just a lot of tension, a lot of frustrations just for the families. They're having these fights daily, potentially other people getting themselves involved. And the constant what ifs, especially with CF, it's not even just the dietary side. What if I'm not doing this right? What if I expose him to this? What if he licks this rock and gets Pseudomonas? Like all of these things are constantly there. What if I'm not giving him the right formula? What if I'm giving him too much sugar? What if? These are all things that can constantly be going through families' heads. So if you have something you think would work, if there's anything you have a question-wise, just ask. Because it could be going through their head, or it's something they didn't think of, and they just need that outside voice to point it out or to just give them some sort of guidance. And especially that support, the encouragement. Like, I know this is hard. I see what you're trying to do. You're doing your best. We are going to figure this out together. And very importantly, This time is temporary. Obviously, every stage is going to have its own challenges, but these stubborn toddlers will change. At least that's what we tell ourselves, and we're getting there. Make sure that you are supporting your families through this challenge. Make sure that you're guiding them, but you also want to be their cheerleader. You want to make sure you're acknowledging what they're doing so that they feel like they are doing a good job. Because if they're already beating themselves down, they're not going to be the best parent that they can be. And we all just want what's best for the patient and to be this care team together. So where do we go from here? It depends. There's not really a good answer for this because everyone is very specific, very different. There's new factors to focus on, and there could be a lot of questions from families about this. So what does this actually look like if they are on highly effective modulators? Because it is an option for so many. For Anders specifically, it's been an amazing resource. Most of his CF issues have been GI related, and most of those we really haven't dealt with. After about 2 months on his Trikafta, when I was writing this slide, he was at 42 pounds. That's 2 pounds within a couple months, which was unheard of for him. But then also, we've spent all this time pretty much giving him, to a certain extent, what he wants, making sure that he's got butter with everything. What do we do now to help kind of pull that back? Which, I mean, for us was relatively easy because, again, he loved his low-fat foods. He loves his fruits, vegetables, all that, which is great. But for families that don't have that, what can you do to support them? How can you kind of guide them into this almost new relationship with food? And then there's also those who are starting modulators very young. Maybe they're not used to this high-fat diet. All of a sudden they have to come off for whatever reason. How can you guide them to be like, it's okay that they need more. It's okay that you need these supplements. Like, it's not an issue. This is just another tool. There's just a lot of factors that can come up, which is why everyone has to be so specific and personalized. And then also, just in general, make sure you're upfront with your families. It's okay to not know an answer. Everything is constantly changing anyway, and honestly, they're probably going to trust you more if you're open saying, I don't know this answer, but let me find it. And having that relationship with families is just very important. It's going to be the best care, again, for that patient. You want to work together. And again, make sure listening and creativity are your two big tools that you can use. Yeah.
Thank you, Katie, for sharing your perspective and Anders' story.
Okay, yeah, we're up.
All right, to wrap things up, Christina and I are just going to share a few best practices from our experiences, both from a nutritional education and a psychosocial nutritional education perspective.
Let me take this out, put this back in. Right. Okay.
Jennifer and I do not have any relationships to disclose. She does have one that's not related to this presentation. So, new diagnosis, nutrition education. Of course, this is always a challenge. You know, parents come in, a lot of them are new parents, they've never been parents before. So not only are they dealing with CF, but they're also dealing with learning a new baby and learning to be parents. So our goal, especially at St. Louis Children's, is to provide a structured education plan that does not, we try not to overwhelm the families. Of course, we adjust our plan based on the families and kind of how they're doing along their journey. So it's important to work with your team to find a plan that works at your center. At St. Louis Children's, usually at our first visit when we meet the family, as far as the nutrition piece go, I usually demonstrate, well, we look at their genetics. If we think they're gonna need enzymes, I look at seeing what we're gonna start, which enzyme we're gonna start. We'll look at their insurance and just kind of go from there. During that visit, I will discuss enzymes, malabsorption, why the enzymes are needed, and then I will demonstrate giving the enzymes. If we have any samples available, I will provide samples. That way then the parents feel comfortable they have some going home. We also provide applesauce, spoon, and everything in our newborn kit. We also discussed starting salt supplementation and why this is important. So the two things we only start at the first visit are the enzymes and the salt. I provide handouts of information with what I've talked about during that visit, but also my number, so that way they can feel free to contact me if in the days to come, if they have any questions. Some of the families, the babies are sleeping or they just fed before they came, so they don't want to feed while they're there. So we don't get to demonstrate and do a feeding in clinic. So it's just talking it through with the families. So especially with those families that I don't get to do a feeding with them in clinic, I usually follow up with them a couple days after we see them just to see how the enzymes are going, to see if they have any questions regarding giving the enzymes. And of course, if it's available, if the patient were to stool while they're in clinic, we collect the stool and send it off at that point in time. Usually during the second visit, we'll see how enzymes are going, just see how all that is going. But that's usually when we start our fat-soluble vitamins. We try to kind of wait to start those a little bit. And I always warn the families that they are disgusting, they're gross, and they stain. So don't put grandma's pretty little outfit on whenever they're giving the enzymes. And then if we don't have a stool sample, we collect one at that point in time. Usually at subsequent visits for the first year of life, we will monitor growth velocity, check heights, weights. If we don't have a stool or if we need to check one, depending on what the first values showed, we will repeat the fecal elastase as needed. We'll check the fat-soluble vitamin levels somewhere between 4 and 6 months of age, or at least 3 months after starting the vitamins. We've had a couple babies lately that have had lots of issues with reflux, so we've kind of delayed even starting the vitamins, just related to the parents and their comfort level with feedings and reflux. So we've kind of waited to start the vitamins, so we will check their levels a little bit later, but definitely 3 months after we start them. We follow per the guidelines every 3 months, or every month for the first 6 months, and then every other month for the first year of age. We have had a couple families in the last year or so that have needed a little bit more education or a little bit more follow-up. So we have seen them every month, even during that 6 to 12 month period. Or if the baby, depending on growth and how that's going, that's also another factor as far as if we need to adjust that as well. Every visit, besides, like I said, checking growth and their growth velocity, we'll monitor stools, assess enzyme dosing, talk with the parents about that, and just continue to assess their understanding of the education that we've been providing with them. We do try to follow up too in between phone visits. I'm lucky I have an iPhone. I have a lot of families that text me from my work phone. Hey, they're having stool issues. Can you call me? That kind of thing. So it makes communication very easy, which is good and bad. But we generally, so if those of you that don't know, if you're new to CF, the CF Foundation, the infant care guidelines that were published back in 2009, this is the chart and kind of the information on when you would start various things related to enzymes and checking stools. So if you are new to CF and you haven't seen the guidelines, you want to make sure you check those out and look at this chart.
All right, so Christina very nicely outlined what the recommendations are and how to work with families and what the recommendations for different visits would be. I'm going to talk a little bit, kind of going off what Katie said about being creative. I'm calling it tailoring, but it's the same thing. So not every family is the same, right? We have these recommendations that should be followed. All families need this education, but they might need it at different times and in different ways. So just keeping that in mind. I know there's a lot of pressure to get a lot of education in those first few visits, but if the family's not hearing you, it's all to waste. So, thinking about tailoring, when 3 areas kind of came up. The first one is the family's stress level. So it's stressful to have a baby, and parents of children without kids with CF have a lot of emotional issues, especially postpartum issues in mothers. And obviously cystic fibrosis just adds to that stress. We all know we don't learn best when we're under a high stress environment. So if we have a little bit of stress, we learn really well. But if we're too stressed, we just can't let that information in. So thinking about best practices in that case, so just check that the family's coming along with you, check their understanding. So, I just told you a lot of information about enzymes. Can you, just to make sure I'm giving you the right information, can you tell me what you heard? So kind of that teach back method, checking and having them kind of repeat back to you the information that you just gave to them. Encouraging other people to come. I always love it when I see the babies with a family friend or grandma comes in too, and that's really helpful to have another person who might be less stressed listening. Obviously, the written materials, note-taking, it should be expected. We want families to leave with information and not just have to keep it all in their head. We always, I think, these days think that families prefer electronic materials, but when we've done surveys in our site among our patients and in other populations, parents actually still really like the written handouts. They like to be handed something. So keeping that in mind, it's kind of hard to do these days, but parents seem to prefer that. And just expect that you'll repeat yourself a lot, right, to those families, and that's to be totally expected. So the second area of tailoring might be to the family's needs, and this is focused on where they might be coming from, what their background might be. They might have a nursing background, but not in this area, or they might have no background, no experience with medical issues at all. So kind of keeping in mind tailoring to where the family's at in terms of their understanding. It's very common for people to have trouble using health information that we provide. We say you should provide information that's at a 4th grade reading level or less, should be kind of the expectation, but we often have difficulty kind of talking in those terms. There has been a little bit of research on health literacy among adults with CF, and it does seem to make a difference in their health care. So for families, people might be different types of learners that you might just ask them, and we've kind of made this more of a routine part of our center, asking them, how do you like to receive education? Do you want me to demonstrate for you? Do you want me to watch you do it? And then just providing education through multiple methods. Observing when you can. I like how, I think, Christina, you mentioned you like to actually watch them take the enzymes or show them how, and that's so important to actually demonstrate or to actually watch how they're doing it at home. And then, kind of in the interest of sharing tools, there's a lot of technologies out there. There's apps where they can track some nutritional information at home or get some more education. There's a newer Cystic Fibrosis Action Plan that includes some nutritional information. I know that's a little hard to read, but it's where families can keep track of things like stools. So using the Bristol stool chart, or keep track of, giving them pictures of where their child might be at with their weight, or types of foods that you're recommending for them. So, some families do better when you give them something that involves a lot of pictures versus just a lot of text or just telling them the information. And then the last area of tailoring that I'm going to talk to you about is by families' preferences. So we are all different people. We all deal with stressful environments in different ways. We've done a little work in this at our site about looking at how coping style might impact the way that people want to get education. So the pictures here are from a handout that we give to our newborn families that just asks them to think about, how do you usually cope with stress? Are you an emotional coper? Are you a problem-focused coper? Do you like getting lots of information all at once, or do you like getting little bits at a time? And we ask families to think about that and tell us what they prefer. So if you're more of a person who distracts yourself, try to get away from that emotion at first, then maybe we just give you the very basic information first and give you more later as you're comfortable. There's not one perfect way that people learn, and, going by the way that they prefer to cope will help with their longer term adjustment. And then kind of the other thing about family preferences is helping to build these parents' confidence. I think Katie, so nicely talked about that, you're feeling pretty, especially around feeding issues, it's a very emotional laden topic for families. It's very basic to feed your child. So normalizing mistakes, encouraging reaching out, encourage, parents to take care of themselves, doing that, how are you doing, kind of check in with parents. Encouraging them to, give themselves, be their own best cheerleaders, especially during those difficult times. And then, we all kind of talk about this. There's a lot of advice out there. So try to, if you're ever in doubt, check with your medical team, but certainly get all that outside support from grandmas, grandpas. When people ask you to help, let them help you. So that can all build confidence for our families. And then we just wanted to end with another cute picture of Anders, but we're going to switch now to our question and answer period, and we're going to ask all of our speakers to come back up for the questions. Thank you very much.
We have about 10 minutes remaining for questions. So if you have any questions and you haven't put them in the app, feel free to come up to the microphone.
Or do you want me to go ahead with one?
Why don't you start with Susan has it first.
Yeah.
Hi. Hello again.
I think that our first question is, do you think you could start PERT later when exclusively on human milk, since human milk contains lactase?
I think they mean lipase.
Okay, lipase.
Yeah. Yes and no. Yes, we always think that very low volume, low rate of breast milk, a baby could tolerate that without starting enzymes. But we recently had a baby in the NICU with quite a few complications, one of them being neck. And so we had to restart the express breast milk very slowly. She did better the second time, but got up to about 50 mils per feed. She was taking feeds every 3 hours and had very poor weight gain. However, to complicate things, she had started enzymes previously before the all the secondary complications, and parents thought that she reacted very strangely to the enzymes. So in the parents' mind, they were very hesitant to restart enzymes until she reached over 60 mils. So it was, you kind of have to, as you were saying, individualize it. And we did. We went along with the parents' wishes. And she's home now, but in some ways I wish we would have started a more adequate dose of enzymes sooner. Perhaps we could have promoted earlier weight gain. I just heard from my colleague yesterday, and finally, at 5 months of age, this baby came into clinic yesterday at Nationwide Children's, and she was gained an average of 36 grams per day in 1 week. So it was a very slow start. So I think you just have to kind of look to see, how do the parents feel, and look at the weight velocity for the baby.
Thank you. We had a comment from the app. Michelle put in a comment that said, from her understanding, Relizorb is currently undergoing trials in NICUs through the USA. So this will hopefully be an option in the near future pending FDA approval for children less than 2 years of age.
And I did not mention that because at Nationwide Children's, we have not used Relizorb for babies in the NICU on enteral feeds, partly because it seemed like the most recent babies we've had coming through our NICU status post-meconium ileus have not needed enteral feeds. They've been able to take oral feeds and work their way up to an adequate amount of mostly breast milk. But I think, Michelle from Dayton, you've used Relizorb, and I know at Cincinnati they have, and I think Terry has used it at Rainbow Babies. So and Liz, you have. So if you're interested, these dietitians would be better, more knowledgeable in starting Relizorb. The one thing that I did have an article, I didn't show my references, they were beneath the little boy picture, but there was one article about breast milk being used in a continuous feeds, that you lose a lot of the fat. I don't know how breast milk would work with Relizorb, or if it's possible, but maybe one of these other dietitians you could speak to after the session.
Thank you. Our next question is for Melissa. Is there long-term feeding aversion associated with placement of NG tubes in preterm or term infants?
Great question. That's a question we get a lot from parents too. So, short answer, no. If we're thinking about what it's being paired with, you're not typically inserting it while the baby's eating. So at least they're like kind of keeping it separate from the eating experience. But as far as like sensitivity or like difficulty with swallowing, or, I think the biggest thing is infants sometimes eat better orally when there's no tube. However, you're looking at the greater picture of if they need a tube to receive this vital nutrition while they're working on building up. If they're not able to safely and comfortably eat enough by mouth to get what they need to grow and what they need for their nutrition, that tube is necessary. And you want to make sure that you're, minimizing the negative stimulation to like their face, making sure their tape is, not being ripped off, things like that. You're being really gentle with their face, but in general, no, there's nothing long term. Now, if they do need a tube, like if they do need tube feeds long term, especially with CF, I think it makes sense to explore a G tube sooner rather than later, because if they don't need all of that negative stuff going on in and around their mouth, it's great to not have it because it will help oral feeding progression, but I wouldn't necessarily say that that's the thing that's going to stop or harm or cause long-term feeding problems from an oral feeding standpoint.
Thank you.
Thank you. The next question is for Karen. When using the CDC growth curve for infants, do the weight velocity goals for grams per day weight gain still remain the same?
Yes. So.
Oh, okay. All right. Our next one is for Katie. Is there something you wish your CF team would have or would not have said to you regarding Anders' nutrition and growth struggles?
If anything, maybe a little bit more information, I guess, about when a G-tube would be considered. That was a really big stress that I thought about frequently. You see it a lot in like the parent groups, that kind of thing. So it was always this like, gotta get this in so that we don't need the tube, which I think talking about it as a tool also would help, because that's not how I saw it at the time. And now looking back, trying to think of what might have made things easier for everybody involved, it probably would have been a good tool, but just, it depends on the family. I don't think it's a good idea to go up to every family and be like, here's a G-tube, here's why we're gonna do it, here's when we're gonna do it. But that's just a consideration.
One more? Yep, good. All right, I think this last one is for Karen. For a fecal elastase that was obtained from an ostomy, what would you expect the result to be? Falsely low or falsely high? I'm sorry, Susan, not Karen.
Karen could probably answer that. Well, from our experience when we've done a stool elastase on patients, older patients with questionable pancreatic insufficiency or sufficiency, the stool elastase can come back lower with looser, more liquidy stools. So, and even for those babies that have been reanastomosed, their stools are going to be loose anyway. So you may want to, if they do it shortly after the reanastomosis, it comes back low. We have repeated it again within a few weeks just to double check.
And I'll add one follow-up to that is we've always thought with pancreatic elastase, we know a lot from genetics, but the thought's always been it's more harm to not start enzymes when you should than to start enzymes and need to discontinue them later on in terms of growth and nutrition.
All right, thank you very much to our speakers today, and thank you for attending our lunch. And if we have additional questions, please come up. Our speakers can stay for a couple of minutes.